Today I'm going to talk about the respiratory evaluation and management of people living with ALS. I have no financial disclosures at this time. The learning objectives for my talk today, so we're going to talk about a little bit about some ALS characteristics. We're going to talk about neuromuscular respiratory disease progression and evaluation. We're talking about modes of non-invasive ventilation. We're going to talk about some troubleshooting issues with non-invasive ventilation, and then we're going to talk about treatment beyond non-invasive ventilation. So just my one slide summary. Amyotrophic lateral sclerosis, ALS, like we've heard before, incidence of 1 to 3 cases per 100,000. There's no ethnic or racial predisposition. Progressive motor neuron disease has effects on both the upper motor neurons, which is spasticity, dysarthria, dysphagia, lower motor neurons, extremity weakness, atrophy, fasciculations. Respiratory failure is the most common cause of morbidity and mortality in people living with ALS. And this is because the way the disease works, it affects both your inspiratory muscle strength, your expiratory muscle strength, and your bulbar muscles. Your inspiratory muscle strength is important because it contributes most to ventilation or breathing, right? Expiratory muscle strength is required for airway clearance or secretion management, coughing, clearing your lungs, blowing your nose. Bulbar muscles are important because they help protect your airway so that we don't aspirate our secretions. When we talk about types of chronic respiratory failure, there's 2 main types of chronic respiratory failure. So there's type 1 respiratory failure, which is hypoxemic respiratory failure, usually not the case of people living with ALS. People living with ALS tend to suffer from what we call type 2 respiratory failure or hypercapnic respiratory failure. They cannot ventilate or breathe appropriately. When we talk about the natural evolution or progression of disease of people living with ALS, people start off kind of with their normal breathing, right? And then as things progress, you start to see people first start to have symptoms when they're sleeping at night, and specifically when they're in the stage of REM sleep at night. During REM sleep, we have a lot of atonia in all of our muscles, and so we tend to hypoventilate more during those periods of time. As your forced vital capacity drops, then you start to see disruptions in both your non-REM and your REM sleep. And then as the forced vital capacity drops even further, then you start to see symptoms of daytime respiratory failure. So they may start to have fatigue during the day. They may start to have more shortness of breath during the day. At any point during the course of the evolution of disease, you're always at risk for chest infections because as the respiratory muscles get weaker, you're not clearing your secretions. It's just another graph kind of showing that, we have abnormal gas exchange during sleep. You start to see the disturbances. They start to have symptoms of the disturbances. Again, you're waking up kind of with morning headaches. You're not feeling rested. Then they start to have symptoms of abnormal daytime gas exchange. Start to have symptoms during the daytime, and ultimately leading to their respiratory failure and death. So what is the role of ventilation support in the care of ALS? So this is one of the early studies. It's a retrospective study looking at 122 patients living with ALS. And it looked at the initiation of non-invasive ventilation, and it started at a forced vital capacity of less than 50%. And they looked at 3 different groups of patients. So they looked at people who used non-invasive ventilation for over 4 hours a day. They looked at group 2 that used non-invasive ventilation kind of a little bit, like maybe a couple hours here or there. And then they looked at group 3, which showed people that used no non-invasive ventilation. And what you can see here is by this Meyer-Kaplan curve is that the people that use non-invasive ventilation most actually had a prolonged survival. So we see that they actually survived much longer than the people that used it a little bit, and then people that didn't use it at all. We also saw in the same study that the use of non-invasive ventilation decreased the rate of decline of the forced vital capacity. So again, using non-invasive ventilation decreases the slope of the line. So here you have this kind of severe slope. Once you start using non-invasive ventilation, the line kind of flattens out a little bit. People who use it just a little bit, it's a little bit less than the group 1 people. And then group 3 people who don't use it at all have a much rapid decline. We know that non-invasive ventilation extends life of people living with ALS. And that was confirmed in this randomized control trial that was done in 2006 by Dr. Bork. So this was a randomized control trial looking at 41 patients living with ALS, and 22 of them were treated with non-invasive ventilation and 19 were treated with standard of care. And it included patients both with bulbar symptoms and non-bulbar symptoms. And what they saw in this was that when you take all comers, there was an extension of life in people living with ALS of about 205 days. So if you think back to the Kaplan-Meier curve that Dr. just showed previously of the use of riluzole and that tiny little improvement, use of non-invasive ventilation is much more effective, right? So early non-invasive ventilation, early respiratory support is what prolongs life in people living with ALS. This graph down here shows people who are non-bulbar, and they had a significant improvement in their lifespan, as opposed to people who were bulbar actually did not have any improvement in survival, but they did notice a benefit in improvement of their quality of life. This was a meta-analysis done by Dr. Letzen in 2012, and again, it looked at all the different trials looking at the uses of non-invasive ventilation. And basically, the conclusion that was derived from this meta-analysis was that non-invasive ventilation improves survival in people with ALS. So when you are struggling with a disease that there are no pharmacotherapies for, respiratory support is important. So great, non-invasive is good, right? How do I get this for your patient, though? So you need to do a respiratory evaluation first. So like Dr. just said, clinical evaluations are very important when you take care of people living with ALS. So patients may not be aware of the symptoms of respiratory muscle weakness, right? So you really have to ask them and kind of derive it. If you ask someone if you have shortness of breath, they're going to say, no, I feel fine. But then you have to kind of dig a little bit more into it. So you have to ask them about their sleep quality. Do they feel refreshed in the morning? Has their sleep quality changed? Did they used to sleep really good at night and now they don't? Do they feel short of breath laying down at night? So like all of a sudden, is someone sleeping in a recliner chair? Is someone sleeping on like 4 pillows at night? Do they feel short of breath if they lay down flat? Do they have sleepiness during the daytime or fatigue? Are they just getting tired doing activities that they used to do on a regular basis? Have they noticed a change in their voice, right? So vocal tone. Has their voice character changed? Has their ability to talk loudly changed? Do they have restless sleep? Do they toss, turn? Do they feel like they're just not getting good deep sleep? Do they wake up with morning headaches? Has their cough changed? I have every patient that comes and sees me in clinic cough for me. I'm always like, oh, has your cough changed? They're like, oh, no, my cough's fine. I was like, can you cough for me? And it's like, and so, people aren't always aware that how weak their respiratory muscles are. And then, do they have any impaired memory or concentration? So, like, are they not thinking clearly? Signs that, again, that they may have some CO2 retention and are not ventilating appropriately. Your physical exam is going to be very limited. Most people living with ALS are going to have diminished breath sounds, but it's not always the most effective exam. Respiratory testing, right? So there are some very important tests that should be done on a routine basis for all people living with ALS. So one is spirometry, or lung function testing. So we do spirometry at every visit that patients come to see us. So every 2 or 3 months, they get spirometry. And we do spirometry both upright and supine. And we're looking to see if there's a drop in their forced vital capacity. And it's really important to do it both upright and supine because, first of all, no one typically sleeps sitting up. And so you really want to assess their diaphragm function when you take away the use of gravity. So if someone lays down, their forced vital capacity may drop. And it's important to see if that's happening because you don't want to delay therapy, knowing that this is the most effective therapy, to wait if their forced vital capacity upright is still good. We do a maximum inspiratory pressure or a negative inspiratory flow. So again, this is looking at the diaphragm function, and we're looking to see, is this weaker? And we again do this test upright and supine to see if we can optimize when is the best time to start someone on non-invasive ventilation. We commonly do overnight oximetries. So we commonly will set people home and let them do an overnight oximetry test to see, like, okay, do they have evidence of nocturnal hypoxemia? Do they have evidence of REM-related hypoventilation? You can do an arterial blood gas, but usually we find in our clinic that it's not necessary to qualify people or to really assess them. Both of the first 2 testing are much more easily done on a regular basis. They're non-invasive. And very rarely do we do polysomnograms or PSGs. It's actually not required to as part of the diagnostic criteria to initiate someone on non-invasive ventilation. So this is a forced vital capacity or flow volume loop of a normal person and a person living with ALS. And you can see, again, that they have a restrictive thoracic disease, right? So there's a restriction in their forced vital capacity. This study showed that it's important to do both upright and supine because there's a fall of more than 25% in the supine position, and that suggests diaphragm failure. So like if you're only screening people upright, you're going to miss almost a quarter of people that could be started on non-invasive ventilation early and therefore get them acclimated to therapy and prolong their life. So if you see this group right here, this group actually did not see failure until the supine was performed. So it's really important to make sure that you're aggressively screening people. Again, nocturnal overnight oximetry. So this is a overnight oximetry test looking at a patient, and you can see where they start to have these periods of nocturnal hypoventilation or hypoxemia. If you time it out, and if you know anything about sleep medicine, it usually times out kind of in the same periods where you would see REM sleep. But it's, again, early intervention, early screening to make sure that you're assessing people comprehensively to see if when's the best time to start them on non-invasive ventilation. So this is the slide. If you're going to take a picture, this is the important one. So this is the Medicare guidelines for how to qualify someone for non-invasive ventilation, okay? So ALS is a neuromuscular disease, but it's also just by CMS guidelines is a restrictive thoracic disease. So you have to have some documentation of a neuromuscular disease or a restrictive thoracic disease. Diagnoses like, it doesn't necessarily have to be ALS. They could be motor neuron disease. It could be myopathy. You just need something that's going to qualify them. And then you need to meet just one of the 4 following criteria. So you either need to show that the patient has an upright or supine forced vital capacity less than 50%. It is not specified that it has to be upright or supine. So if you do someone's spirometry in clinic and you see that they're 60% upright and you lay them down and they're 47%, they qualify at that point, so you can start them at therapy. You need to do a maximum inspiratory pressure less than -60. So again, upright or supine, that is a good way to qualify people. You can do an arterial blood gas where you see if they have carbon dioxide retention or a PCO2 greater than 45. Or you can do an overnight oximetry. And an overnight oximetry test, you only need to prove that they have oxygen saturations less than 88% for 5 minutes. This does not need to be a cumulative 5-minute period. It just needs to be 5 minutes over the whole course of the night. So if you meet any one of these criteria, you could qualify your patient for a non-invasive ventilator at this point. So let's talk about non-invasive ventilation. Let's break it down. So non-invasive ventilation, BiPAP, we're going to use a bunch of different terminology, but we're going to kind of break down what happens in non-invasive ventilation. So when we talk about non-invasive ventilation, this is kind of the pressure time waveform. And so what we see here is a couple different variables. So when you do non-invasive ventilation, you're going to have an inspiratory pressure and an expiratory pressure, but then there are other factors or other settings that you can adjust that will improve ventilation for people living with neuromuscular disease. So when we talk about EPAP, we're talking about expiratory positive airway pressure. So this is the lowest pressure set during exhalation. So it helps kind of stent open the airway a little bit, helps keep open the basilar segments of the lung. The trigger is the point where you switch from the EPAP to the IPAP. And it's really important, and I'll kind of talk a lot about why the trigger is important. So if you think about it, if you have diaphragm weakness, you want to make that trigger really sensitive, right? Because patients aren't going to be able to trigger it. So you don't want to make it very challenging. So like you or I that have a functioning diaphragm that works, the trigger can be less sensitive. But for a person living with ALS, you want that trigger to be sensitive so it's not a lot of effort for them to get the support of the ventilator. The rise time. So the rise time is the time it takes from the device to transition from the EPAP to the IPAP. How fast does the air come at the patient, right? So that's going to come into effect when you're talking about patients versus spinal onset versus bulbar onset, right? So if someone has bulbar weakness, a lot of laxity of their oral pharynx, giving them air really fast is going to almost cause some spasticity of their upper airway and make them feel like they're suffocating when they get it. Inspiratory time. So inspiratory time is the time the device spends during IPAP. Cycle is the time where it switches from IPAP to EPAP, and then inspiratory positive airway pressure is the maximum pressure that the patient will reach during ventilation. So when we talk about modes of non-invasive ventilation, I think it's really important to make sure that we're very clear on what people living with ALS need, right? So you'll hear of BiPAP, and BiPAP has so many different subcategories to it. There are some people that get treated for sleep apnea and they're on a BiPAP machine. But those people on a BiPAP machine with sleep apnea are on a spontaneous mode, right? So they only get support when they trigger the machine. That is not good for a person living with ALS because at some point they're going to get some muscle fatigue and they're going to need a backup rate. So when we talk about backup rates, we're going to talk about 2 different modes of BiPAP machines. You're going to talk about your spontaneous timed mode and your pressure control mode. Both of these modes come with a backup rate, which is important so that when the patient hypoventilates or doesn't breathe enough times, that they're still going to get appropriate ventilation. And then over the last 5 to 6 years, there have been evolution of newer modes or auto modes, which are good for hypoventilation. And these are volume-assured pressure support modes. So these are modes that you can tell the device what size breath you want it to give, and the device will adjust the pressures as needed to make sure that the patient always gets constant ventilation. And this is really great for people living with ALS because this is a progressive disease, right? So you may see someone in March and their forced vital capacity may be 55% upright and 47% down, and you lay them down and you start them on therapy, and then 3 months later you may come back and their forced vital capacity may have dropped to like 30%. And in between, if you're on a fixed mode of an inspiratory and expiratory pressure, their tidal volumes will drop and they may not feel like they're getting appropriate support. Whereas in a volume assured pressure support mode, the patient will always be getting consistent ventilation. I'm not even going to talk about spontaneous mode because your patient should not be on spontaneous mode. So we're just going to ignore that one. But when we talk about ST mode, so we're looking at two different breaths here, right? And this is important because on some devices, and there's different manufacturers, so there are two main companies that do devices. One is a company called ResMed, one is a company called Respironics. And there are some differences between the two that are not important right now, but if you have questions, I can answer them. But when you look at the first breath is a breath triggered by the patient. And what you see here is that the patient triggers it and they get this tidal volume here, they get the rise, they meet this IPAP that, let's say, is at 10. And then the next breath is the breath device, the next breath is the one given by the machine. And you can see there's two different breath sizes, right? So the spontaneous breath is the patient's is only inspiring for this amount of time. Whereas on the breath that's delivered by the machine, they're getting this full inspiratory time. The longer the inspiratory time is, the larger the breath is. The larger the breath is, the less work of breathing the patient has to do. And so it actually decreases the work of breathing and rests the patient better. When you have small breath, big breath, small breath, big breath, it can lead to dyssynchrony, and then the patient may feel uncomfortable. When you put someone in a pressure control mode, again, it's BiPAP with a backup rate, but it's called pressure control mode. And what you see here is that whether the patient is getting a spontaneous breath or whether the patient is getting a device-triggered breath, they're getting the same inspiratory time on both breaths. And see, the ventilation is a lot more consistent. There's a lot less dyssynchrony. You're giving them better overall ventilation. When you talk about volume-assured pressure support mode, so what we see here is that the patient triggers the breath. The machine this is up here is where the target is that the machine wants to get to, right? So that's the breath size that I tell the machine I want it to get to. The first breath that happens, the patient gets a inspiratory pressure up to here. The breath is a little bit smaller. The machine senses how the breath is coming back, and it adjusts the next breath so that it will get a larger inspiratory pressure to get closer to the tidal volume that you're desiring. So it will constantly be adjusting itself to make sure that the patient is getting consistent ventilation. Why is inspiratory pressure, or why is inspiratory time important? So when you think about it, people living with ALS have diaphragm dysfunction. Their lungs are like balloons that sit in their chest, and the basilar segments of their lungs deflate. You get atelectasis. Well, you want to recruit that lung because if that lung is open, there's more areas to ventilate. It decreases the work of breathing. There's a thought process that, well, if I just give them a higher inspiratory pressure, then I'm going to open up that lung. But that's not really how it works. So if you think of the lung has different zones, and there are some that are high resistance and there are some that are low resistance. And so if you increase the inspiratory pressure, all you're going to do is you're going to overextend the low resistance segments. So all you're doing is overextending these apical segments of the lung, but you're never really recruiting these basilar segments. So you still have this collapsed lung and it's still affecting your ventilation, your work of breathing. If you increase the inspiratory time, the total time that you're at that inspiratory pressure, you actually improve recruitment of these basilar atelectasis. You open up that part of the lung. There's more areas to ventilate. The work of breathing goes down. The patient's better rested. That's why it's really important. So when you're picking your settings or working with your respiratory therapist or talking to your pulmonologist, inspiratory time is so important because it really does help decrease the work of breathing for people living with ALS. Issues that affect noncompliance. So what we know is that this was a study looking at patients diagnosed over a 4-year time period. And we know that tolerance always tends to be much better in people who are limb onset as opposed to bulbar onset. There is a population of people living with bulbar ALS that just do not tolerate bi-level ventilation or non-invasive ventilation. And we know that this, we know that those people tend to actually do worse because they just cannot tolerate it, and we know that non-invasive ventilation does improve prognosis. As disease progresses, the forced vital capacity is going to drop. There's going to be increased ventilation needs, right? So patients may start to notice more symptoms during the daytime. So again, they're not going to tell you they feel short of breath because they're not doing a lot of activities. But you got to have to tease around it. So you have to be like, so are you getting fatigued in the afternoon? Are you not finishing your meals? Is your voice getting weaker in the afternoon? Do you take naps now? And so those are ways that you can assess that they're starting to have some daytime weakness. The options at this point are you can increase their use of their home non-invasive ventilation machine. You can initiate mouthpiece or SIP ventilation, or you can start to even go down the road of thinking about tracheostomy or leak speech. In our practice, I typically ask patients, walk me through your day. I tell them to kind of tell me everything that they do during the day, and I try to figure out times during the day that they're just sitting there watching TV or on their iPad or playing on their phone, and think of ways that they can start using their BiPAP machine at home during the day. Like, just sit on it for like an hour. You don't have to go lay down. Just put it on, and you can still talk. You can still participate in activities, but at least rest those respiratory muscles. I kind of explain it in the sense of, there are things that you still want to do in life, right? They want to go out to dinner, or they want to go to their grandchild's game, or they want to go to their child's game. And so the way I play around the idea of increasing the use of non-invasive ventilation is like rest those respiratory muscles so that the things that you want to do, you can still do. So, if you're just sitting around the house doing nothing, put it on. And then when you go out later at night, you won't be as tired, or you may not be as fatigued. Mouthpiece ventilation, so let's talk about that. So SIP ventilation, I'm not sure how many of you are familiar with it, but the benefits of this is that it allows support when needed with speech and eating, but does not interfere, right? So like people can take a breath when they want to. They get ventilatory support when they need it, but they don't need to be on a mask all the time. It allows a break from the mask interface, so it decreases the skin breakdown, it decreases skin irritation, and psychologically, it allows people not to feel like they are committed to being fully vented, right? Disadvantages of it are gastric distension. You can't use this during sleep. You get some continuous airflow. When we talk about mouthpiece ventilation or SIP ventilation, there are some things that you need to know. So it requires a home mechanical ventilator. There are two different categories of non-invasive ventilation devices. So there are the respiratory assist devices, which are your BiPAP machines that you traditionally think of that have to be plugged into a wall. And then there are your home mechanical ventilators. These are portable mechanical ventilators that have internal batteries to them. Okay, to do mouthpiece ventilation, you need a home mechanical ventilator. When you're picking your settings, there are a variety of different modes that you can use. You can use a volume controlled or assist control mode. You can use a pressure control mode. You can use a pressure support mode. It's going to be very important for you to work with your patient, your respiratory therapist, your home DME to find out what's going to be best for your patient. You want to make sure that you're giving the patient enough support or breath so that they can get a large tidal volume. So when you calculate it based on their height and their weight, what size tidal volume they should be getting, you kind of actually want to go a little bit larger than that because they're during the daytime, they're going to require more support, and they're using it to speak or eat, so you want to make sure that they're giving them a larger lung capacity. When you pick the settings, you're not going to give them a backup rate because you're just going to let them breathe when they want to. The inspiratory time, again, comes in, and it's very important because the longer the inspiratory time, the more lung you're recruiting. The more lung you're recruiting, the decreased work of breathing. You can give them different types of flow patterns. That all comes down to the comfort. You don't want to give them any positive end expiratory pressure or EPAP or PEEP in this setting because, again, they're going to be talking there during the day. And you want to make sure that your alarms are set appropriately. This is kind of what it looks like to do mouthpiece ventilation. So there's usually a home mechanical ventilator. This is a Trilogy by Respironics. There's also the Astral by ResMed. But there's usually a device set up to it, and then there's this arm with a mouthpiece here. And patients will just take breaths when they need to. So they may be talking, take a breath when they need it, but they don't need to do it consistently. A side note, and very interesting, that something Dr. Wolf and I have noticed over time is very few patients with ALS actually SIP ventilate. So we do neuromuscular disease across the board for muscular dystrophy and spinal muscular atrophy and ALS. And the Duchenne's and the Becker's and the muscular dystrophy people, those younger children actually or young adults, I should say, do really well in like SIP ventilation. When you try to offer SIP ventilation to people living with ALS, they don't always do it. There's maybe a handful that do it, but most of them actually prefer just to have the portable ventilator and put it on a backup rate. It's just something we've observed. I can't explain it one way or the other, but it just tends to be something that we have observed. At some point, disease is going to progress, and you're going to reach a point where non-invasive ventilation may not be optimal. So this was a dilemma that I recently had with one of my clinic patients who had been on non-invasive ventilation 23 hours a day and came into the hospital with a pneumonia and kind of had to decide where we went from that standpoint. It's very important to know that you can ventilate someone equally effectively non-invasively as you can with a tracheostomy. There is no there is no extended life survival with a trach now that we have such good non-invasive ventilation. So it used to be, back in the days of Stephen Hawking, that tracheostomy was the only option you had. But now with these home mechanical ventilators and the great mask options and the settings that we can do with a home mechanical ventilator, I can give you the same ventilatory support with a non-invasively as you can do with a trach. There are a subset of patients that may benefit from a trach. Usually these are patients that have really bad bulbar disease with really bad secretions, and they keep aspirating those secretions, and they lead to recurrent respiratory infections. And so a tracheostomy may be beneficial in those cases for people who need more deep suctioning to prevent respiratory infections. But again, very clearly, I want to make sure you know that it does not add any benefit or prolong living for people living with ALS. It just is a different mode of ventilation. So when we talk about global tracheostomy rates, let's talk about America versus the world, right? So in the United States, about 10% of patients actually end up with a tracheostomy. This, when you actually look at the Japanese literature, about 32% of those patients end up with a tracheostomy, and that's very different. When you talk about people caring for people living with ALS, you would ask most people, we can do everything we can with non-invasive ventilation, don't need to do a tracheostomy. The Japanese tend to not use as much non-invasive ventilation, and that's why they tend to have higher numbers of tracheostomy patients. 79% of Americans and 36% of Japanese seldom or never suggest or encourage tracheostomy invasive ventilation. However, 70% of both American and Japanese neurologists would not choose tracheostomy for themselves. 13% of home mechanical ventilators were trached out of the Eurovent study, and a Canadian study looked at about 12 to 13 home mechanical ventilator users per 100,000 were 72% of those were on non-invasive ventilation, and 18% of those were on tracheostomy. And so, again, it's something you really have to think about and talk about with your patient. You have to have a conversation. It's not just the next step in treatment. It's really important because it can lead to caregiver burnout, right? So ALS, a progressive disease, people living with ALS become more and more dependent. A tracheostomy is another added level of respiratory support, and it's a mental and a physical difference and change for the caregivers, right? So if someone is non-invasively ventilated, I think someone thinks it's a lot easier to manage than a tracheostomy, which is probably true because a tracheostomy is open to the air, you have increased suctioning needs, you have increased care needs. And so we know that independent of home invasive ventilation, people living with ALS and their caregivers commonly suffer from the following symptoms. So they suffer from depression. And this is more common in women and younger caregivers because women tend to be the caregivers most times. There's caregiver overload. There's just burnout, or financial burnout. It's just people are living longer. We have done amazing things in non-invasive ventilation, respiratory support, airway clearance, nutrition, that are letting people live with ALS longer. But the longer they live, they increase the financial burden, the increase of the caregiver burnout. Caregivers tend to lose their personal identity. They don't look at themselves as like the spouse anymore. They look at themselves as like my whole role is the caregiver. And the caregiver has a lot of different duties, right? So as a person living with ALS, their caregivers are responsible for positioning, feedings, communication devices, adjusting the eye gazes, clearing the writing board, airway clearance, transferring from bedpan to bed. And so that's a lot of work. And so a trach is just one more added element of that. When you do have a tracheostomy, let's talk a little bit about that. So the tracheostomy tube itself can cause an obstruction. It's a physical obstruction in the airway, so it causes poor airflow. It can increase the airway resistance. It can increase the work of breathing. To create sound with the tracheostomy, the tube depends on having adequate supply reach the vocal cords. So when people have a tracheostomy, it doesn't necessarily mean that they can't speak. You can do what's called leak speech. So you're not taking away that ability. But if someone couldn't speak before a tracheostomy, they're not going to speak after a tracheostomy. So if someone gets a tracheostomy because they have recurrent infections and they can't get off a ventilator, but they can still phonate or speak, then there's a chance that they may still be able to speak afterwards. But if they were completely bulbar and didn't have any speech before, they're not going to speak after. So kind of the anatomy here. So you have your tracheostomy going into your airway. Here is your balloon or your cuff. When the air goes in through the trach, it goes in here, but then what you want to do is you want to let the air come up above and go through the vocal cords. And so that's kind of how they're going to be able to phonate during leak speech. So the fundamentals of leak speech are the patient must be able to tolerate the cuff being down. You need to adjust your tidal volume so that you can give them a larger tidal volume to compensate for the loss that's going to go through the vocal cords so they can speak. It's really important to suction the patient, right? So there's a lot of oral secretions that get stuck on that balloon of a tracheostomy, and if you deflate that balloon, it's all going to go right into the lungs and cause a pneumonia. So you want to make sure that you're clearing those secretions beforehand so that you're not putting the patient at risk for increased pneumonias. We speak on our exhalation, right? So we take a deep breath in, and then we talk. But on leak speech, what happens is you actually speak on the inspiration. And so it takes a little bit of time, or the inhalation, I should say. It takes a little bit of time for the patients to adjust and learn how to speak. They tend to speak in kind of small, broken sentences, but they can speak and they can communicate, which is really important because there's got to be a way for them to tell you what you need. There are times where a speaking valve can also be beneficial just to help strengthen the voice. Skip that one. So the efficacy of tracheostomy on survival. So again, getting back to it, this was a prospective study from 2001 to 2010 and looked at 116 patients, 76 of them requiring tracheostomy, most of them for bulbar disease. 38 proceeded with the tracheostomy, 21 of them were done in an acute setting, 17 were done non-emergently. 19 patients required a tracheostomy secondary to poor airway compliance. The 1-year survival was 79%, and the 10-month, and they had an average survival of about 11 months. If you go back to non-invasive ventilation, what I showed on the earlier slides, non-invasive ventilation can prolong life up to 205 to almost 400 days. So we actually can get just as long of survival non-invasive ventilation as you can with a tracheostomy. Quality of life with tracheostomy, so people living with ALS who have a tracheostomy actually don't notice any difference in their quality of life, whether they're on non-invasive ventilation or tracheostomy and ventilation. However, and both patients, whether they're on non-invasive ventilation or tracheostomy, would choose to be ventilated again, which is a good decision. Caregivers, though, of people living with a tracheostomy rated their quality of life lower than the patient. So they actually felt more caregiver burnout. So it's a discussion that needs to happen with the patient, with the caregivers, to make sure everyone's on board with this decision. And then there was a very small subset of patients that rated their quality of life good and did not regret their decision. So to summarize, non-invasive ventilation is a proven therapy to both improve survival and quality of life of people living with ALS. And there's a much better response in it with people who are non-bulbar than bulbar. Early and frequent respiratory assessment, both upright and supine, is important so that you can start people on therapy earlier. All patients using non-invasive ventilation require a backup rate. Do not ever give your patient a BiPAP machine in a spontaneous mode, no matter what someone will suggest to you. Increasing the inspiratory time will help improve lung volumes, recruit basilar atelectasis, decrease work of breathing. Increasing the tidal volume in patients with leak speech to compensate through the airflow going through the vocal cords is very important. And patients do not require a tracheostomy to provide full ventilatory support. It's very important. One thing that I didn't talk about, but I wanted to kind of lead as a teaser before the break for Dr. Wolf, is that this was a study that came out in 2018, and this looked at the role of non-invasive ventilation and airway clearance and the improvements in survival. So this was a retrospective single-center trial, and it looked at 474 patients living with ALS. 403 of them were on non-invasive ventilation, and 71 were non-users. And it looked at the use of daily non-invasive ventilation and mechanical insufflation-exsufflation therapy, or cough assist. And the outcome was survival based on the forced vital capacity based at initiation. So if you look at the first column here, when you start people on non-invasive ventilation with a forced vital capacity of 80%, and they're using it 8 hours a day, and they use a cough assist, they live about 30 months. Well, that's really hard. The only way you're going to get someone on that is if you screen them with an overnight oximetry and they have desaturations. And so, again, that's why aggressive screening across all different modalities is important. But when you start to look at the people who have a forced vital capacity less than 50%, so when they qualify for it based on Medicare guidelines, they're using it over 4 hours a day, and they're using lung volume recruitment with a cough assist, they're living on average about 26 months. So you've given them 2 years of life if you give them early respiratory therapy with non-invasive ventilation and aggressive airway clearance with a cough assist. If you start them on non-invasive ventilation at 50% and they're using it 4 hours a day, but you don't give them a cough assist, you're still seeing that benefit of 15 months, but you're not getting that extra almost 12 months of therapy. And then if they don't use any non-invasive ventilation, they don't use any cough assist, their life expectancy is about 13 months.